very lucky to welcome on our next clinical Pearl presenter, Paige Hanke. Paige is the PGY2 emergency medicine pharmacy resident, or I guess we should say probably the last few days of that, coming to us from Detroit Receiving Hospital in Michigan. Paige, welcome. How are things doing up in the mitten?
Very good. How are you, Nick?
Did I use that phrase appropriately as a non Michigander?
Yes, for sure. It's shaped just like, you're right, just like a mitten.
Okay. Um, well, very rarely do we get to say the phrase all that and a kitchen sink. Wait. Let's take that back a second. Paige, one of the therapies that we can use in some of our most critically ill patients involves something called a lipid sink. So I think from there, the floor is yours.
Thank you so much, Nick, for that introduction. I'd like to start off with a patient case, actually. So imagine this. EMS rolls in with a 29-year-old male found unresponsive at home. Empty pill bottles are nearby of propranolol, quetiapine, and buprenorphine. He's tachycardic, seizing, and hypotensive. You're pushing benzos, fluids, and you're maxed out on three pressors. But he's still crashing. He's in refractory shock. So what left is there to do? This is where lipid rescue might come into play. So today we're going to talk about a therapy that seems a little out there, injecting lipids to reverse drug toxicity. But for the right person, it can be an intervention that changes the game. So let's walk through what lipid rescue is, where it came from, and how to actually use it at bedside. We'll break down indications, dosing, and tips for utilization. So, intravenous lipid emulsion therapy, or more informally known as lipid rescue therapy, first made waves in the early 2000s. The spark was a patient who went into cardiac arrest after a bupivacaine injection during a routine soldier procedure. Standard ACLs failed the patient, but after a bolus of lipid emulsion, the patient achieved ROSC and fully recovered. This was the first documented human case showing that fat, in the form of a 20% lipid emulsion, could reverse local anesthetic system toxicity, or also known as LAST syndrome. This case was published in 2006 by Weinberg and colleagues, and it changed how we manage certain types of overdose. It proved what early animal models were showing all along, that lipids can work as an antidote when traditional therapies fall short. And from there, the concept expanded, first in the anesthesia world and now in toxicology and emergency medicine. We're using it in select overdoses, including lipophilic drugs. Those that like to hang out in fat rich tissues like the brain and the heart and cause severe toxicities. This includes drugs like propranolol, verapamil, TCAs, and bupropion. These overdoses can cause profound shock, seizures, and cardiac collapse. And when the usual meds fail, lipid rescue becomes a last line potential life-saving option. Mechanistically, the core concept here is the lipid sink, as Nick mentioned. Injecting a fat emulsion into the bloodstream creates this compartment where lipophilic toxins can partition away from those critical tissues, like the heart and brain, and eventually be eliminated. It also has a secondary mechanism that improves mitochondrial energy production and gives a slightly inotropic boost to the heart as well. When it comes to indications for use, we are all LAST syndrome is well known, but let's look at some non-anesthetic toxicities that benefit from lipid rescue, especially when standard therapies fail. These include beta blockers, such as propranolol is a big one due to its highly lipophilic properties, calcium channel blockers, such as verapamil, amlodipine, TCAs, such as amitriptyline, with its widening of the QRS and hypotension as a potential toxicity, and your antipsychotics, such as bupropion, clozapine, and quetiapine. Now, it's important to remember that lipid rescue therapy isn't a cure-all, and the American Academy of Clinical Toxicology, or the AACT, and other professional groups emphasize that lipid emulsion therapy should only be used for specific severe toxic cases, typically when patients are unresponsive to conventional treatments. Toxicology experts have made it clear that this is a high risk intervention with limited evidence for many of the drug classes listed above. And with that said, when you're faced with refractory overdose, especially in a life threatening situation, lipid rescue therapy may offer that last chance at saving the patient. The decision to use lipid therapy should be guided by your clinical judgment and collaboration with your poison control center. They are available 24/7 to give you real time guidance on dosing, drug specific recommendations, and management protocols for lipophilic drug overdoses. Their number, and make sure you have this saved, is 1-800-222-1222. If you haven't already, put it in your phone, in your code cart, and share it with your team members. It's important that you reference the Poison Center as it's one of the best resources in these high stake situations. All right, so moving on to some important literature. One early report published in the Journal of Medical Case Reports in 2010 described the use of lipid emulsion therapy in a patient with life threatening verapamil overdose. This patient presented in profound shock, unresponsive to fluids, high dose insulin, calcium, and vasopressors, so our standard therapies that we would try first. After emergent administration of a standard lipid rescue protocol of a 1.5 ml per kilogram bolus of 20% intralipid, followed by a 0.25 ml per kilogram per minute infusion, the patient had a rapid and sustained hemodynamic improvement. This case was one of the first to document the success of lipid rescue for a non local anesthetic lipophilic drug toxicity, specifically the CCB verapamil, which has a high volume distribution and a strong lipophilic profile. It set the stage for considering lipid emulsion therapy as a potential rescue intervention for other lipophilic cardiac drug overdoses, specifically in refractory cases. Following that direction, a pivotal case series published by Serrani and colleagues in 2008 looked at 3 patients who overdosed on bupropion, lamotrigine, and clonazepam, all highly lipophilic drugs, as mentioned before. These patients were in refractory shock or in refractory seizures, despite supportive care with benzodiazepines, pressors, and intubation. The last line intervention, following suit from our previous studies, was using that standard 1.5 ml per kilogram bolus of 20% intralipid, followed by that 0.25 ml per kilogram per minute infusion over 30 to 60 minutes, depending on the patient case. Outcomes were pretty impressive, with all patients actually improving within 10 to 15 minutes of the lipid infusion. Their blood pressures were stabilized, the seizures were stopped, and 2 patients were actually able to be extubated and discharged within 48 hours with full neuro recovery. 1 patient did develop transient lipemia, but no other major complications were noted. So the bottom line is that these case reports support lipid emulsion as a viable salvage therapy for severe overdosing involving lipophilic drugs, especially when standard treatments aren't working. And so what's the takeaway? We're really not dealing with high quality randomized control trials in toxicology, and we probably never will be. These patients are coding, seizing, and hypotensive, and there's really no time to randomize or to receive consent. And that's why literature is heavy on case reports, case series, retrospective reviews. It's not level 1 evidence, but in toxicology, clinical judgment plus poison center consultation and pattern recognition is how we perform evidence based medicine. So, now let's talk a little bit about dosing of lipid rescue therapy. And this is where things get a bit messy because there really is no validated evidence based dosing regimen, like we mentioned before, for this therapy. So, what we're going to talk through are recommendations from just the major guidelines and expert consensus. Interestingly, the dose is volume based. So, the American Heart Association recommends starting with that 1.5 ml per kilogram bolus over 1 minute, followed by an infusion of 0.25 ml per kilogram per minute for 30 to 60 minutes, with a maximum infusion dose of about 10 mLs per kilogram. But lipidrescue.org, which is a great bedside resource that was recommended to me by the toxicologist at my current institution, goes a bit further with some practical tweaks. They suggest repeating initial boluses 1 to 2 times if the patient is still in cardiovascular collapse. If hypotension persists, increase the infusion rate to 0.5 ml per kilogram per minute, and to increase the total dose to 12 mLs per kilogram. For those of you who are thinking, is there potentially a lower maintenance dose to avoid some of the toxicities that are associated with this medication? There actually is a more conservative dosing strategy that the website recommends. based on some expert opinion, and that is giving that original loading dose of 1.5 mLs per kilogram, and then giving that infusion of 0.25 mLs per kilogram per minute. But then we would transition to a maintenance infusion of 0.025 mLs per kilogram per minute. So as you can see, there's variation in dosing. Beyond that, there are some protocols that recommend using higher boluses up front. Others recommend skipping the infusion altogether and just giving those continuous boluses for the max dose. And some dosing, talks about ideal body weight. So as you can see here, we do recommend dosing based on total body weight. But if you have an obese patient that you might want to consider using ideal body weight in to reduce those risks of toxicities, such as fat overload syndrome. And that brings up adverse effects that are associated with this therapy. Fat overload syndrome is rare, but if you do have too much lipids too fast, this can cause pancreatitis, hyperlipidemia, or pulmonary complications. As highlighted by Hayes and colleagues in a systematic review from 2019, lipid rescue therapy has the potential to cause acute kidney injury, cardiac arrest, ventilation perfusion mismatch, acute lung injury, venous thromboembolism, fat embolism, and if your patient is on ECMO or was an ECMO candidate, this may cause some circuit obstruction as well. So this is something to consider in your patients that are at the last line therapies. And so that's why many experts recommend staying below that 10 to 12 ml per kilogram dose to avoid these toxicities. So some key takeaways here is that you've got options when it comes to dosing, but always reference your own hospital protocols. And when in doubt, call your poison center. They are available to give you real-time guidance. So this dosing strategy we just discussed is all based on a 20% intralipid product. This is the product most commonly mentioned in literature and the recommended lipid emulsion by the American Society of Regional Anesthetics and Pain Medicine for LAST syndrome treatment. It is a soy-based product that is commonly used in TPN formulations, so most hospitals already have it in stock, but maybe not so much in the emergency department, so something to consider adding to your stock. Additional research is needed to determine whether other commercial lipid formulations are equivalent or superior to the known standard for lipid therapy, such as SMOF products. The 20% lipid emulsion product does come in a 250 or 500 ml bag. With these larger doses, you may need more than one bag to obtain the correct dose. So let's discuss an example patient of a 75 kilogram patient to kind of get an idea of how much intralipid we may need. To administer the initial bolus, you must pull up 1.5 ml per kilogram from the bag. So for your 75 kilogram patient, this would be approximately 112 mLs, and this can be pushed over a minute. Then onto the 0.25 ml per kilogram minute infusion, the patient would need about 19 mLs per minute. So don't forget, we must max out the dose for this therapy at about 12 mLs per kilogram. So for this patient, our max would be 900 mLs for their total dose. So after the bolus, we would have about 780 mLs left to give if we divided this remaining among that 19 mLs per minute. This would run over approximately 41 minutes total. So as you can see, for this 75 kilogram patient, we would need about 4 250 ml bags or 2 500 ml bags in order to properly dose this patient. And I don't know about you guys, but obesity is a common comorbidity in my current emergency department. And so this would mean that for a 150 kilogram patient, we would have to pretty much double this dose, meaning that we would need about 8 250 ml bags or 4 500 ml bags for reference. If you happen to only have 10% intralipid product, this may mean that you may need to double all of these doses and the products needed. So I suggest going to take a look at what products you have available and adjusting your protocols accordingly. So some quick pearls to remember when thinking of treating your refractory lipophilic drug overdose patients. Lipid Rescue was born due to LAST syndrome, but has found a home in other life-threatening overdoses as salvage therapy. Use it in your refractory shock patients, not as a first-line agent. Know your dosing, stock it appropriately in the right concentration, and practice using it is important for proper use in your emergency department. And remember that toxicology rarely has randomized control trials available, so using clinical judgment and protocols are your best tools. And lastly, when in doubt, call your poison center. They have 24-hour access to toxicologists for dosing help and case based evidence. So don't guess on something with this high stakes. Thank you so much for having me on, Nick. It was really a pleasure, and I hope you guys got a lot out of this.
Paige, that was awesome. I don't know how people didn't get it. I mean, we talked through dosing body weight. You even talked through what do we do when inevitably the 20% lipids go on shortage and we have 10%, right? And um, how to cap it. Love the real life example. Sometimes I just need to see that math in front of me to really point it out. And then for the listeners, this was not talked about between Paige and I ahead of time. I love you included on the alternate dosing protocol one of, I would say, kind of one of my EM tricks, essentially, because these patients are sick, right? So they have what I call the tower of power. They already have 6 IV pumps going. So sometimes they don't have a free line to actually do that, the infusion. So sometimes having to give a repeat bolus per se as you're trying to sort those things out or all things you have to do. But I love that you highlighted the fact that multiple times these are people, get your poison center, your local toxicology involved. Be sure to look at what you're doing locally. If you don't, if this sounds awesome, these are things you need to be consulting your ER, ICU, CT. Like this is a big multidisciplinary kind of group here. So, Paige, this is awesome. Appreciate you coming on, sharing all of this knowledge into what I think is one of the more hands-on kind of pharmacist intensive therapies in toxicology and emergency medicine. So appreciate you sharing all those tips and tricks with us.
Yeah, thank you so much for having me. Yeah, I really agree. Like the operational side to it is something that you really have to consider with how many bags you might need during this. And the bolusing was such a great point. Like if you have so many lines, you really don't want to infuse this with other medications. So thank you so much for having me on.
Pleasure's here. Thanks, Paige.